good evening, good afternoon, Dr. Mohammed and Dr. Mark Rebo. Nice to see you, both of you.
Good
Nice to see you.
Excellent. Both of you, the sound looks very nice, very clear, and hope mine is the same.
Okay, so we are ready. At least I am ready.
Mohammed is ready. So we will start our webinar after the World Congress in Toronto. So this is Suhail from Dubai. Welcome all our audience. There's a huge number of participants from Middle East and Asia, Africa in this webinar. I'm so glad to see this. This is a monthly webinars that Middle East North Africa Stroke Organization is conducting, mainly for stroke specialists and residents across the region. Our webinar, which is number 34 for this month, October 2023, is hosting two distinguished speakers. Dr. Mohammed Al-Mikhlafi, who is assistant professor from Calgary University, head of the stroke program, and researcher in the field of cerebrovascular disease and stroke. At the same time, Dr. Al-Mikhlafi is a neurointerventionist, and he's very close friends of Dr. Suhail. Welcome, Dr. Mohammed Al-Mikhlafi.
Thanks, Professor.
And I'm so honored today to have Dr. Mark Rebo with us. Mark has been in Dubai for several times, and I know him for a while. He's an intervention neurologist from Hostel Hebron in Barcelona, and he had his fellowship at University of Texas, Houston. I will not mention which year that was, and his research work over the last 20 years was focused on improving the stroke care across the region globally. And he has been a PI in multiple study and co-PI in several studies across the region. And tonight we will have these two distinguished speakers who will update us about the stroke and stroke management. So the first speaker is Dr. Mohammed Al-Mikhlafi, who will give us an overview look for the new data coming from the World Stroke Congress in Toronto. Dr. Mohammed will try his best to summarize everything new in that Congress within 25-30 minutes, Mohammed. That's very hard work, and to summarize a great 3 to 4 days that in Toronto. So then we'll have Dr. Mark Rebo, who will give us an update about medical complication of stroke. And I'm sure that, as usual, Mark is doing great work there. So with no further delay, I would like to thank all our participants. Would like to thank Boehringer Ingelheim for their support for this webinar. And just to remind everyone who's attending this webinar that you can use the Q&A bar to address all your questions, which will be discussed at the end of this webinar, which should be between 90 minutes to 60 minutes. So Dr. Mohammed Al-Mikhlafi, with no further delay, you can share your presentation.
Thank you very much, Dr. Suhail, again for the kind introduction and for the invitation. And just a correction, I'm not the head of the stroke program. Andrew Demchik is the head of the stroke program, but I'm medical director of the stroke unit at the University of Calgary here. So I'll just share my screen. Perfect. And so I'm kind of obviously with the World Stroke Organization Congress, there were lots of interesting science presented, but I thought I'll just focus on the clinical trials which were presented during the conference and hopefully give you some overview. Obviously, most of the material I'm going to use were kind of copyrighted as per the WSC disclaimer. However, these are only for educational purposes, and I'm sure that this hopefully won't infringe on any copyright. And I would like to thank Dr. Maria-Andre Benzini, who provided and took most of these pictures that I'll be presenting and sharing with you today. So these are the 6 trials that I thought I'll share with you. I thought I'll give each trial about 4 to 5 minutes to discuss the findings, the backgrounds, and take-home messages from each one of those, starting from endovascular treatment to IV thrombolysis and then neuroprotection, moving to secondary protection, and then the ANNEXA 1 trial for prevention of intracranial hemorrhage. or treatment of intracranial hemorrhage. So to start with, TENSION is a randomized trial that tested the efficacy and safety of thrombectomy in patients with large core strokes. It was led out of the University of Hamburg in Germany, but involved multiple centers in Europe and in Canada. And prior to TENSION presentation in WSC, there were already 3 randomized trials that showed that patients with large core benefit from reperfusion with thrombectomy. These trials were RESCUE Japan Limit, SELECT-2, and ANGEL Aspect. However, all these trials either use patients from a selected population, for example, Asia, Japan, in case of RESCUE Japan, and China in ANGEL Aspect, or used advanced imaging, whether with perfusion or MRI in these all trials. And so in most stroke centers, the argument that we rely on CT scan of the head and CT angiogram to make the treatment decision, and therefore TENSION was set to test that hypothesis among patients who were selected for thrombectomy using CT and CT angiogram. So CT perfusion or MRI were not mandated for inclusion of the patient. They planned a sample size of 665 patients, and the main inclusion criteria that they'd like to bring to your attention is these were anterior circulation strokes, so terminal ICA or M1 occlusion, aspects of 3 to 5 based on visual assessment, so they didn't rely on automated aspect calculation, moderate to severe NIHSS, and patients had to be independent prior to the stroke, and they enrolled patients up to 12 hours from the time of last seen well. The main exclusion criteria is patients with tandem occlusion, i.e. they have a cervical carotid occlusion as well as intracranial occlusion, or patients who are likely to require stenting. And with that, the study based on the visual assessment, mainly using non-CT, non-contrast CT scan of the head. They've done some web-based training for participant on aspect interpretation, and they randomized patients one-to-one to receive thrombectomy versus usual care, which doesn't involve the thrombectomy. And the patient were stratified according to the time of onset and NIHSS. The follow-up was as per routine, 24-hour imaging, and then they followed patient clinically at 24-hour, 1 week, and 3 months, and finally 1 year. The primary outcome was the median modified Rankin scale. So they used the entire range of the Rankin scale as opposed to using 0 to 1 or 0 to 2. But they collected these as secondary outcomes, and they also looked at some safety outcomes. As I was saying, the study was conducted in 8 European countries and in Canada, 40 sites altogether. They enrolled patients from July of 2008 until February of this year. And they enrolled at that point, at the time of the stoppage of the trial, they enrolled 253 patients. I should say that the trial was stopped early after all the SELECT-2 and RESCUE Japan and ANGEL Aspect were published, and they was stopped at the first interim analysis, and 253 patients enrolled. When we look at the baseline characteristic, fairly balanced given the relatively small sample size, but patients were about 2/3 of them had approximately M1 occlusion, 1/3 had terminal ICA, and about 40% in the treatment arm and 34% in the medical treatment received IV thrombolysis. The median time from onset to randomization was about 2 hours, and median time from onset to groin puncture was 4 hours, so relatively early from onset time. When we looked at the imaging characteristics, 80% of the participants only were imaged with CT, but a few received MRI. Based on the investigator evaluation, so the site evaluation, majority of the patient, almost 2/3, had aspects of 4 or 5, but when an independent core lab looked at the images, there were actually about 12% who had an aspect of 0 to 2 and 16% in the medical arm, but the majority of the patients were in the aspect of 3 to 5. A few had a good aspect, but again, this is post kind of randomization and independent core lab adjudication. Nonetheless, the median MRS, as suspected, and many of you may be aware, showed that there is a significant decreased disability among patients who received endovascular thrombectomy. with a median modified Rankin scale of 4 versus a median modified Rankin scale of 6. And for people who are not aware, a modified Rankin scale of 6 indicates death at 90 days. So when we look at the bar chart for the modified Rankin scale distribution, we see that half of the patient in the medical treatment actually died compared to 37.1%. And these results were highly significant for the primary outcome. When we look at the patients who, per protocol analysis, this is sensitivity analysis, looking at the median MRS, there was also clear benefit in favor of thrombectomy over medical treatment alone. For secondary outcome, when we look at the modified Rankin scale 0 to 2, 17 patients in the thrombectomy arm versus 2%. Similarly, 0 to 3, there was also a highly significant in favor of thrombectomy, and also quality and patient-reported outcome were all in favor of thrombectomy over medical treatment alone. 90-day mortality was significantly lower in the thrombectomy versus the medical treatment, but it was 40% in the thrombectomy, which highlight that those patients have severe stroke, large stroke, and although the thrombectomy does improve outcome, those patients are still sick, and there is a substantial percentage of them that would unfortunately die within 3 months of the stroke. These are some of the outcomes, and primarily, I think that parenchymal hemorrhage is of interest because some of the other trials showed increased risk of hemorrhage among patients who received thrombectomy, and in the tension trial, there was no difference in the parenchymal hemorrhage or in symptomatic hemorrhage, and partially perhaps because those patients were already severe. Looking at this kind of forest plot for subgroup analysis, sorry for the quality of the pictures, but basically all of these parameters point toward benefit of thrombectomy. And so in this pragmatic trial, because it involved only looking at the aspects and CT angiography, patients who received thrombectomy had significantly better outcome and less mortality compared to patients who received medical treatment alone without any safety concern. And this supports the use of CT scan and CT angiography to make treatment decision for patients with large core. And these results were consistent with the previous other trial of thrombectomy in patients with large vessel occlusion. The tension trial has been published on the same day in the Lancet, so it's available, and I think it's the only of the other trials that was published. The second trial that I'd like to present is the ATTEST trial, so using tenecteplase for thrombolysis. So those are not necessarily thrombectomy patients, but all comer with stroke. And this is the tenecteplase versus alteplase acute stroke within 4.5 hours of onset, or ATTEST-2 trial led by Keith Muir at the University of Glasgow and conducted in the UK. And basically the rationale, as perhaps many of you are aware, that alteplase was the thrombolytic agent of choice since the NIMS trial has been published in 1996. However, we are looking for a medication with a better efficacy, better reperfusion, better safety, easy administration as a bolus in case of tenecteplase versus the 1-hour infusion, and potentially of a lower cost. And that's what prompted many researchers to trial tenecteplase, which has been used as the thrombolytic agent of choice in patients who have acute MI. These are a summary of the trials that looked at tenecteplase. The biggest of them were the NOR test, which tested a 0.4 milligram per kg and didn't find a difference compared to alteplase, but unfortunately didn't meet the non-inferiority margin. NOR test 2 showed harm with 0.4 milligram kg tenecteplase among patients who are going for thrombectomy. But the ACT trial was the one that has similar design to the ATTEST-2 and tested all comers with stroke symptoms, randomizing them to 0.25 milligram kg of tenecteplase versus alteplase, included 1,600 patients, and showed the non-inferiority of TNK over TPA for patients with MRS 0 to 1. And so with that, ATTEST was fairly similar to design in that it was a randomized parallel group, a pragmatic trial, meaning all comer with stroke symptoms, whether they have vessel occlusion or not, whether they had CT angiogram or not. So patient within 4.5 hours, clinically eligible for thrombolysis, were randomized after consent was obtained to receive either full dose TPA or tenecteplase at 0.25. And by the way, this is half of the cardiac dose of tenecteplase. And then the outcomes were kind of as standard 24-hour imaging and 5-day NHSS, and then they collected 90-day outcomes. They collected a number of secondary outcomes. The primary outcome was the MRS distribution, so median MRS, and then the secondary outcomes were kind of various MRS cutoffs, quality and partial index, and safety outcomes as well. So the study was powered to identify the non-inferiority of tenecteplase with a sample size of 1,870 patients, allowing for 10% loss of follow-up, and they designed it for a hierarchical analysis, first to test of the non-inferiority, and if the non-inferiority assumption was met, then they test for superiority. And so that is basically the intention to modified intention to treat group, about 885 in the tenecteplase arm and 891 in the alteplase arm, but those are the number of patients who completed the 90-day outcome. The groups were fairly balanced in terms of baseline characteristics, medical history, representative of the patient population that we typically see. The median NHSS of the participant was 7, so moderate stroke, definitely disabling to warrant thrombolysis. And additional imaging, so 81% of the patient received a CT scan of the head, but 16% received CTA. So only 16% of the patient has CT angiogram, which reflect the pattern of practice at the UK at the time of this trial was done. Patients were kind of treated early, onset to randomization of 137 minutes, and onset to treatment arm of 140 minutes roughly in both patient population. And the final diagnosis of stroke was confirmed in 96% of patients in the treatment in the tenecteplase arm and 93% in the alteplase arm, and only 11.6% versus 13.2% of participants underwent thrombectomy. So relatively moderate stroke, not severe, but different from the ACT trial, which included more severe stroke patients. When we looked at the primary outcome, the assumption for kind of proportional odds was met, and they done a shift analysis showing that there is an adjusted odds ratio of 1.1 in favor of tenecteplase, which showed that tenecteplase was indeed non-inferior to alteplase. However, it was not superior in comparison to alteplase. These are the raw numbers of the patient. We don't have the percentages, but you can see the scale here of the percentages that all kind of seem to point toward higher 0 to 1 MRS and even higher 0 to 2 in favor of tenecteplase. There was no safety concerns related to mortality or symptomatic hemorrhages, 2.3% versus 1.7% in the alteplase, and similarly in the ECAS. When we look at parenchymal hematoma, PH2, 4.3% in tenecteplase and 3.1% in the alteplase. All of them didn't meet the significance level. And the investigators did a pooled kind of analysis of the aggregate data from other trials, and they kind of suggest that there is a suggestion of superiority of tenecteplase over alteplase in all the trials that tested a similar dose of tenecteplase with an odds ratio of 1.2 almost. And with that, they basically showed that tenecteplase is non-inferior to alteplase. Superiority was not significant, and the 90-day outcomes were all in favor of tenecteplase without any safety concerns. And with that, these are now 2 major trials on all comers of stroke that showed that tenecteplase is non-inferior to alteplase, and hopefully that may result in a change in guidelines to recommend tenecteplase as an alternative to alteplase. Shifting gears to neuroprotection, so ESCAPE Next trial was presented next, and ESCAPE Next trial came at the foot, kind of following the ESCAPE NA1 trial, which showed that there is a potential effect modification of neranetide. So neranetide is an inhibitor of cytotoxicity, showed promising results in primate and then in initial kind of phase 2 clinical trials. The ESCAPE-NE1 trial, however, which randomized patients who are undergoing thrombectomy to receive NE1 versus placebo, didn't meet its primary outcome. However, when they looked at the subgroup of patients who didn't receive alteplase, there seemed to be a significant difference in favor of neranetide, and it's neuroprotective. There is improved MRS of 0 to 2. This is the no alteplase, while in patients who received alteplase, there seemed to be no benefit of neranetide. And the hypothesis at that time that neranetide was inactivated by alteplase, and therefore ESCAPE-NEXT was designed to test this hypothesis. This is again the same kind of non-alteplase. So basically, it replicated ESCAPE-NE1. So all participants were patients who were planned for thrombectomy, but they were not eligible for thrombolysis. And so they plan to enroll up to 850 patients who are all selected for EVT without thrombolysis, small course, so aspects of 5 or more, and within 12 hours from onset, and they were randomized 1-on-1 to receive placebo or neranetide, and the primary endpoint was the MRS 0 to 1 at 90 days. The patient had to have either an ICA or MCA occlusions. They included major M2 or proximal M2 occlusions as well. Patients were randomized within 12 hours, and basically they didn't have an upper age limit independent prior to the stroke. And as I said, CT scan of the head had to have an aspect of 5 or more, so relatively small core and moderate to good collaterals on either multiphase CTA or CT angiography or CT perfusion. And so patients had to receive the medication prior to reperfusion. If the patient already had reperfused and the interventionists are already on their way to close the groin, patients were not randomized to the trial. And with that, the trial was conducted during COVID, so starting at almost 2020, international in North America, and Europe, and Australia. And enrolled 850 patients. So the trial enrolled the full sample size, the pre-planned sample size. Patients were fairly balanced, although there was kind of no difference in terms of baseline characteristic, but mostly white or Caucasian population. Baseline medical history wasn't significantly different. Patient with past COVID infection, 7.1% in this placebo arm and 8.6% in the neranetide. And patients with current COVID were almost 5% in the placebo and 3.1% in the treatment arm. Baseline in HSS was 16, reflecting the severity of the stroke, and the rest of the imaging and clinical characteristics were adequately balanced. Patients were mostly unwitnessed stroke onset within 12 hours still from treatment time, and the imaging kind of reperfusion technical outcomes were excellent. So almost 90% of all participants achieved successful reperfusion, which was essential for the design of the trial, that for a neuroprotective to be effective, reperfusion has to be established. If it hasn't been, then that really neuroprotection will have minimal effect, if anything. And so with that, it was reassuring to see that 90% of participants achieved reperfusion. However, unfortunately, the trial was very neutral. As you can see, essentially, the modified Rankel scale of 0 to 2 was virtually identical between the placebo and the neranetide arms. There was no safety concerns, but there was no benefit of anyone. 45% of the patient essentially in both arms achieved MRS 0 to 2. No safety concerns, no signal for benefit or concerns with safety in either of the treatment arms. And so with that, the investigators went back to the drawing board. What was wrong? Why a medication that has worked in the primate and had good kind of early phase 2 evidence failed to show benefit? And one of the suggestion is that the primate trial or the animal model trial showed that there was benefit when the treatment was given within 60 minutes of stroke onset and in patients with poor collaterals at that time or large core, and showed significant reduction of the stroke volume. And this will be further elucidated in the Frontier trial that I'll put next. But when they looked at the patient who were randomized within 3 hours, there seemed to be benefit from nirmatrelvir that, as you can see here, essentially the placebo and the nirmatrelvir arms were identical when you look at beyond 4 hours, but prior to that, there is some suggestive of benefit with nirmatrelvir. And so some of the questions, the investigators wondered whether excellent reperfusion without improved outcomes. So although 90% achieved reperfusion, only 45% had good clinical outcome. What is the reason? Why is that? And that's obviously the holy grail in stroke, is to improve, to bridge this reperfusion outcome gap with either neuroprotection or other hopefully modalities. Other possibilities is that the study drug was started within 43 minutes from reperfusion. And as we saw, the animal models use 60 minutes. And so is that a good time or enough of a time to allow for the drug to act? The 12-hour window, is that too long? Animal models use 60 minutes, and there is a suggestion from some of the population here that hopefully about 3 hours might be a sweet spot for neuroprotection or at least nirmatrelvir. Was there an early treatment with a 3-hour effect that the study unfortunately couldn't capture? And was the population the wrong one for cytoprotection, using patients with good collateral, small core? Are those patients going to do well irrespective? Although you could argue that half of those patients had an MRS more than 2, so they were having some disability that required them to depend on others. So in spite of that, of the successful reperfusion and having a small core and good collaterals, half of the patient didn't achieve good outcome. So all these were questions, and there will be lots of debate in the coming literature and publication, in the article itself, in the discussion, and also editorials and review articles to discuss that. But what added a spin of interest to the result was the Frontier trial, which was presented immediately after ESCAPE-NA1. And Frontier is almost a twin trial for using the same agent, nirmatrelvir, but basically it was an ambulance trial. So those patients started the neuroprotection in the ambulance. And just kind of being mindful of time, I'll go quickly over that. It was an exploratory study, obviously, because not everyone with suspected stroke in the ambulance will end up having a stroke. But they thought, what if we started the agent right away, even before imaging, even before IV thrombolysis can be given? And so they plan to enroll up to 558 patients with suspected stroke according to the diagnosis of paramedics. And if they were in question, they could reach a physician on call who would over the phone discuss with them. And patients, basically, they waived the consent for the treatment given that or deferred consent given that the medication has been shown to be safe. So the aim was just to start neuroprotection as soon as possible before thrombolysis, both rapid and slow stroke progressors. So patients with small core, large core, good collaterals, bad collaterals. But the disadvantage of this design is that you'll have a heterogeneous population of suspected stroke, so not all of them will have a stroke. We don't have a measure for stroke severity, and that could be problematic to understand the drug effect. And it's for practically reasons that it will be almost impossible to train the paramedics to conduct the NIHSS reliably, and impossible to randomize patients based on NIHSS if you don't collect it prior. And so and obviously there were significant issues in the pre-hospital setting, like the EMS, there's already a shortage of staff, and to have someone hawking the medication and administering the neuroprotective is required lots of training and work, so kudos to the investigators. These are the principal inclusion criteria. So suspected stroke using the LAM score, so Los Angeles Motor Scale of 2 to 5 for inclusion, last seen well within 3 hours and independent prior to the stroke. And they excluded patients who are unlikely to have a stroke based on these kind of measures, seizures, onset, or GCS, very low GCS. This is kind of a picture showing how the drug was frozen, kept frozen in the ambulance and the administration. The trial was enrolled in, that was run in few centers within Canada, Ontario and British Columbia primarily, and they started enrollment in basically in March of 2015, and they concluded in March of 2023, so over 8 years. And they looked, the primary outcome was MRS shift analysis, basically. They looked at some of the safety outcomes as well, and so they ended up enrolling basically 532 patients. Out of those patients, almost 75% ended up having a stroke. But among those who were treated with reperfusion was 100 in patients in the placebo arm and 128 in the niraparib arm. And then again, like obviously this is the population of interest, and the reperfusion arm is the population where the drug is supposed to show maximum benefit. Baseline characteristic, again, fairly balanced, about 15% in the niraparib arm and 21.7% in the placebo arm ended having a hemorrhagic stroke. And but about, as I said earlier, 2/3 in the NA1 or niraparib arm and 56, almost 59% in the placebo had an ischemic stroke. When we look at stroke severity and the time they reached the emergency among patients who had an ischemic stroke, niraparib had more severe stroke in NIHSS of 14 compared to 10, but they didn't include the NIHSS in the adjustment just because it was collected after patients were randomized and received the treatment. But when we looked at the outcome among all comers, so those are the patients who completed the 90-day outcome, irrespective if they had ischemic or hemorrhagic stroke or any stroke for that matter, niraparib was associated with a much improved MRS and lower disability with a modified proportional odds ratio of 1.5 in favor of niraparib, which was statistically significant. So there is significant reduction in disability. And when we look only at patients with confirmed ischemic stroke, this was still significant in favor of niraparib. And we look at patients who received thrombolysis, so even a smaller number of patients, that was even higher odds ratio for lower disability in the niraparib. So very encouraging result. So there was a significant shift in favor of neuroprotection with NA1. There was also lower MRS 0 to 1, less worsening stroke, although that just missed the significance level, but mortality was not different. And there was no, basically, when we looked at the reperfusion population, so those who received IV thrombolysis or thrombectomy, the significance and the odds ratio seems to be even stronger in favor of niraparib without any safety concerns. And so the trial basically showed that it's feasible to start neuroprotection in the ambulance, in the pre-hospital. The primary care paramedics were able to deliver the neuroprotection, which opened the door for future trial. And niraparib has an acceptable safety profile, but it also appears to reduce disability from ischemic stroke when started in those patient populations. So within 3 hours among all comers. And so these two trials together are very encouraging for niraparib, that hopefully it will be seeing more of niraparib, perhaps in a similar population as Frontier. But the time would tell. But overall, unfortunately, ESCAPE-NEXT couldn't show the benefit among patients with thrombectomy who are going for thrombectomy. Moving to secondary prevention with CHANCE-3. So CHANCE-3 was the randomized trial from China looking at colchicine for improved secondary prevention of stroke. So CHANCE showed that dual antiplatelet therapy was superior to aspirin when continued for 3 weeks after TI or minor stroke. And CHANCE-2 only selected patients who had the genotype that conferred resistance to clopidogrel and further reduction of the 90-day recurrent stroke or death. However, an interesting subpopulation of CHANCE showed that patients with high levels of high sensitivity C-reactive protein seem to have a higher probability of recurrent stroke. And with that, they kind of targeted to tackle that inflammation using colchicine. There was some evidence from cardiac literature to suggest that colchicine seemed to reduce overall risk of mortality, stroke, or MI among patients who continued on it once daily, but for about a year time. And so they designed this as a randomized trial with the colchicine at a starting dose of 1 milligram for 3 days and then 0.5 milligram daily for 3 months. And they collected the outcome at 90 days, but also collected some outcomes at 1 year. Inclusion criteria, basically patients with mild or moderate risk TIA or minor stroke. So those were very minor population, minor stroke population, and had a high sensitivity CRP. They excluded any patients with known cardioembolic stroke or basically patients who are unlikely to tolerate colchicine. And the primary outcome was any stroke, ischemic or hemorrhagic, within 90 days after randomization. And impressively, they enrolled 8,343 patients from over a span of 6 months only from 244 Chinese centers. This is kind of the overall breakdown of the trial. Baseline characteristics were fairly symmetric between the patient population. The median NHSS for patient with ischemic stroke at the randomization was only 2, indicating that these were minor strokes overall, but the majority were TIAs. And these are some of the secondary prevention measures that were started in addition to the colchicine versus placebo. When we look at the primary outcome, unfortunately, there was no significant benefit from colchicine in those patient population, and secondary outcomes were all neutral without any suggested benefit in favor of colchicine. This is kind of, you see the Kaplan-Meier curve almost identical. This is the stroke recurrence in the 2 colchicine and patient population, but reassuring to see that only about 6% recurrent stroke within 90 days, speaking to the importance of secondary prevention. Nothing significant in terms of the forest plot. However, as you can see here, like it's a concerning trend that patients with symptomatic intracranial or possibly extracranial, they seem to gather less benefit or potentially be harmed by the use of colchicine. The only one that was kind of trending toward benefit was patient previously on lipid-lowering agent. But patients with symptomatic ICAD had a significant interaction, meaning that colchicine shouldn't be used on those patient population. But this is a subgroup analysis, so interpret that with caution. In terms of any adverse events, some higher GI adverse event in the colchicine arm as expected, but overall the trial was neutral. And why was that? When there was some evidence from cardiac literature to suggest benefit, potential reasons was the duration of treatment was too short at 3 months compared to an average of 2 years in the cardiac literature. And potentially that patient with stroke versus MI respond differently to colchicine. There are 2 ongoing trials for colchicine, CONVINCE, which are for patients within after 3 days from their TIA or stroke, but within a month, and risk thesis trial, which is restricted to patients with evidence of atherosclerotic disease, either in the carotid or the arch. So it'll be interesting because this population seems to be harmed to some extent with colchicine, while this is the patient population that is targeted by the risk thesis. So perhaps the investigator may look at this as a possible safety, but for the time being, no role for colchicine in secondary stroke prevention after TI or minor stroke. Last but not least, the ANNEXA-1 trial. So this is basically a trial to look at the reversal agent for factor 10, active factor 10 inhibitor. And this is for patients with acute intracranial hemorrhage within 6 hours from presentation who received a factor 10 inhibitor, oral factor 10 inhibitor with apixaban, rivaroxaban, or edoxaban within 15 hours and randomized to receive annexonate, which is the reversal agent versus usual care. These are some the eligibility criteria. So patient has to have a kind of moderate size hemorrhage on CT or MRI within 2 hours prior to randomization, and the patient has to have basically not to be comatose or requiring intubation, symptoms within 6 hours, and randomization within 15 hours of the last dose taken. The primary outcome was a composite of hematoma expansion, change in NIHSS, and no rescue therapy required within 12 hours of randomization. The trial was initially planned for 900 patients, but was stopped early after only 450 patients were enrolled for efficacy, meeting the predetermined efficacy measure. Baseline characteristics were relatively balanced, slightly more females in the usual care than annexionate, but the median hematoma volume was relatively identical. Baseline NIHSS was the same between the patient groups. When they measured the factor 10 activity, there was marked reduction in the treatment group as expected compared to the placebo group. And most of the patients who were enrolled were actually on apixaban. About a third were on rivaroxaban, and less than, or roughly about 10% on edoxaban. So those are, but the strongest reduction in factor 10A activity was in those patients on apixaban and rivaroxaban. Not as much, but still 72% in patients on edoxaban. And the trial kind of showed that there is significant hemostatic effect in favor of using annexonate, and hematoma increase was only 11.6% in the treatment group versus 19% in the usual care group. These are some of the secondary kind of and safety outcomes, and as you can see here, there is a trend for increased thromboembolic events in the treatment arm. So the medication seems to have some prothrombotic properties. So ischemic stroke 6.5% versus 1.5% in the usual care. Same for MI, and not much for DVT or PE, which actually was more trending in the usual care arm. No difference in mortality. So although annexonate was effective in reducing factor 10A activity and reducing the hematoma and severity, it didn't really impact death. Overall, forest plot show all the secondary subgroups were trending toward benefit with annexonate over usual care. And with that, annexonate was rapidly capable to reduce factor 10A activity in those patients with acute intracranial hemorrhage associated with oral factor 10A inhibitor therapy. This is a summary slide. If you don't have it, please look it up on the Edmonton Stroke Program, our neighbors north, that really summarize these results. Thank you very much, and I apologize for going over time.
Thank you, Dr. Mohammed. Jazakallah khair. Wow. I can't say more than that. Great presentation, nice review. You went through everything there. And by the way, this is going to be recorded, Dr. Mohammed, and this will be on the website of MENASO. So anyone can go freely to look to this nice review, which is reviewing all the new clinical trials came during the World Stroke Congress in Toronto this year. I will remind our attendees that there's the Q&A box. If you would like to share your question, please don't make it late, so Dr. Al-Makhlafi and Dr. Mark Rebo can go through it. With no further delay, I would like to introduce our next speaker, Assistant Professor and the Head of the Stroke Unit at Hebron Hospital in Barcelona. Dr. Rebo has been in Middle East several times, and he's running one of the best workshop at the level of Middle East when he's coming here. So he's going to speak about the management of medical complication in stroke. Please, Dr. Rebo, you can start.
Well, thank you very much for your kind introduction, for not disclosing the years of my fellowship. Yeah, well, the topic today is related to thrombolysis, to complications. The organizers asked me to, so we just heard a very super interesting speech about cutting edge data presented a few days ago. My presentation is somehow more with more older data, but it's sometimes nice to review the data to understand better what we are doing and how we can safely implement thrombolysis because it's a much needed treatment. So first, I like to show this quote related to my age and my experience, growing experience. I have a lot of experience probably, but because many times or several times, too many times, something that I didn't want happened. But at least the best you can do is learn from it. Second is this world map, in which, since we're talking for the region, the MENASO region, look at that. You guys are a hot spot in terms of stroke. So if stroke is a big health problem in the world, it's especially true in your region. And of course, it has a big burden there. So much more work for you. Now, in the era of thrombectomy, and we hear all day about thrombectomy here, thrombectomy there, thrombectomy, more thrombectomy for more patients, thrombectomy for large cores, thrombectomy for distal occlusions in the late window. Listen, yes, sure, thrombectomy is a great treatment, but we should not forget about the other treatments. First, we should not forget that admission into a dedicated stroke unit with dedicated physicians that are experts in stroke will benefit 100% of our strokes. And this is known for a while now, that specialized care helps to a lesser degree, that's right. It's not a huge impact, but it helps basically all kinds of strokes, to the whole spectrum of strokes, older, younger, severe, mild, acute, subacute, all of them will benefit from that. Then roughly 1 out of 4 patients would benefit from thrombolysis. And this is an effective treatment that we tend to forget when we're talking about thrombectomy. And of course, finally, thrombectomy, very powerful treatment, but we should remember that it applies to a minority of our patients. So let's keep this in mind. Now, the rate of thrombolysis, and this is a map of Europe, and unfortunately, I couldn't find it for your region, but probably, or I'm sure, it's not better than this. So the data in Europe is as shown. The target that the ESO, this is the European Stroke Organization, suggests is that we will treat 18% of all our strokes with TPA, and best case scenario, we can probably treat 20, according to our previous slides, 25%, 1 in 5, 1 in 4 patients, best case scenario can be treated with IV TPA. The truth is the mean rate in Europe, and probably in your geographical region, is below 10%, 7% for us. So a long way to go before we get to more decent numbers and more, we spread the benefits of thrombolysis. Now, what are the main reasons why we do not give thrombolysis? Well, obviously, first would be patient presenting out of the window, and but second is the reluctance of the physician, and this has to is related to physicians might have fears, might not understand very well the benefits and risks, so they cannot weigh them. They doubt, and in doubt they just prefer not to treat. So the purpose of my talk here is to make things clear, to make the data clear. So when next time you are facing a patient that is a candidate for, or a potential candidate for thrombolysis, you lose the fear, you weigh better the pros and cons, and probably, or hopefully, you will decide to treat if the patient, obviously fulfills the criteria. So the main complications, basically, I would say the only important complication is bleeding. Obviously, there are other listed complications that I will mention at the end, but bleeding is what turns it back and hold us from treating many times because we fear the patient will bleed and will experience a neurological deterioration, which many times is fatal. So this is the beauty, but also the problem of thrombolysis. For every 100 patients that we treat, we're going to get to be better or back to normal all these green patients. Unfortunately, a few patients, as compared to non-treatment, we might make 3 patients out of 100 to feel to be worse. So overall, if you do you subtract these 3, it's extremely beneficial for the patients, but with the caveat that we might feel guilty in those few cases in the patient gets worse. But we don't have to think about these 3. We have to think about the whole picture every time we're in front of a candidate. And we need to be able to stop the complications as much as possible and to learn that they are there. And if they happen, to acknowledge that we did the best we could. We tried to avoid it. Sometimes, despite we do everything well, and according to the recommendations, we do not violate the protocols, sometimes it will still happen. But overall, for every 100 patients, we are going to benefit 20, 30 patients. Now, we have all in our mind the list, so we can have these checklists with all the inclusion and exclusion criteria for TPA. We should go through them, and then we are ready to inject or to start the treatment. Here, my work fellow is giving the IV TPA bolus in the CT scan. So what do we know? We know that the more protocol violations we do, we increase the mortality rate. And this is quite old, 20 years old. As I told you, some of the studies I'm presenting here are quite old, but I like to, it's nice to do this review with all, but still valuable data. You see, at that time, there were high rates of protocol violations in some institutions. And this is sometimes very high or too high. But look at this here. We graded in a decreasing order according to sample size. So the sites, or let me point to the last. The sites on the left here are those with the highest sample size. So the centers that have more experience, and obviously, these sites, or it's very clear that the rate of symptomatic intracranial hemorrhage is much lower than all these other sites in which the sample size is lower, so they have less experience. So logically and obviously, with more experience, you get better results in terms of avoiding symptomatic ICH after thrombolysis. Because you understand better, and you probably do less protocol violations. So very important to keep them in mind. For example, there is contradictory data about the incidence of ICH after thrombolysis and the management of blood pressure. Some would say that the blood pressure will induce the bleed. Some other would say that the bleed starts and then as a reflex, there is an increase in the blood pressure, and it's a consequence and not the cause. Anyhow, whatever it is, cause or consequence, the guidelines clearly recommend us, and this is one of the few things that we can do to avoid protocol violations, that we need to give the thrombolysis only when we achieve a good control of the blood pressure and keep it below these figures as I'm showing here. Hemorrhagic transformations, again, we fear this a lot. Keep in mind that they are all not the same. And there is this classic classification, if I may say, differentiating for these little blood spots, and then more confluent, and finally these parenchymal hematomas, and or even remote that happen in uninvolved territories. So look at this. Remember that hemorrhagic transformation, although infrequent, also happens in controls. So patients who did not get IV IV thrombolysis, they also get or may develop a symptomatic intracranial hemorrhage, a PH2, even a PH2 in 1.3 of the patients. This obviously is increased when patients receive thrombolysis, and obviously among those patients who receive thrombolysis, a PH2 or a fatal ICH, per definition, will lead to less good outcome. So it favors controls, right? But this applies only to a minority of the patients, right? Also, what are the factors that may increase the chances of a parenchymal hematoma? So it doesn't look to be related to time to treatment. As you can see here, there's no higher incidence when you get closer to the 4.5 or beyond 4.5 hours. It's not more frequent with older patients, but it is more frequent with more severe, with larger cerebral parenchyma involved. So yes, it is. It seems to be more frequent here with those patients with an NIH higher than 16 or even higher than 22, right? Keep that in mind. So yes, the larger or the involvement of the brain, the worse the NIH, the higher the probability of a symptomatic ICH, and this applies 4 to 6% of the patient will have an ICH. Now look at this. So you might say, no, maybe we should be very cautious with severe NIHs. But on the other hand, when we talk about benefit, clinical benefit in the ranking score, also you can see that more severe patients are those who benefit more in terms of MRS reduction. So yes, high NIH have higher rates of ICH, but they do also have higher benefit from TPA. So the fact that the patient has a very severe stroke means probably that, yes, there is a slight increase of hemorrhage, but there's more benefit. And yes, here the benefit is related to the time and as I said, to the NIH, and also it seems like all ages benefit. So what happens with ICHs? In the first days, first hours or first days, they lead to higher rates of death. And there's going to be more death among the ICH patients, and that applies to 4 to 6% of the patients. But if we take overall all the patients, this is what we're seeing, including the mortality related to ICH, you can see that on the long term, there's a clear benefit favoring thrombolysis in terms of mortality only. Now I'm not talking about disability. In terms of mortality, even if we account for the death in the first days for ICH, patients who received IVTPA have lower mortality. Now, there are several scores, and this is very interesting data. There are several scores that grade the risk of ICH among patients, candidates for TPA. So the HAT score, the SRIV, the SCAPAN, the DRAGON, they take into account the variables that you can see here, and you can assess or quantify the risk of an ICH beforehand. However, the paradox is that those patients with a higher risk of developing an ICH are also those patients who most benefit from TPA. So yes, we need to acknowledge that we might cause a bleed, but we need to understand that this is widely compensated by the benefits of recanalizing this artery in these patients. So these scores that grade your chances of hemorrhage, yes, that they are nice to have, but at the end, they are not much of a use, because you still know that this patient will benefit more from TPA despite the higher risk of ICH. So my suggestion here, my recommendation is always spend couple of minutes, 2-3 minutes after you or when the patients come in, to inform the family. This is very important. You inform the family about what I just said, and this will avoid misunderstandings. Everybody understands the risks and the benefits. I clearly explain the family what are the risks of this medication, but I also explain that there are most of the times compensated. These risks are widely compensated by the higher chances of improvement. So if everybody is well informed, if everybody understands the risks and the consequences, then most of the time everything is going to go well. But in the event that there is a complication, you can handle things better because we all feel more comfortable because it's not a surprise for anybody. But again, we need to focus on the potential benefits. And yes, explain the part of the risks, and now we feel more comfortable. Now, a few words about when and how we should give this treatment, because I still hear about what should we do with a candidate for thrombolysis when he's far away from a comprehensive stroke center here in Barcelona. Should we prioritize the thrombolytics at the closer center, or should we go all the way and skip the closer center and delay the thrombolysis in order to advance thrombectomy? So this is our, I would say, well-known trial, the RaceCat trial, but I'm showing it here because, let me go all the way to the next slide. This is what happened with our trial. When we bypassed the local stroke center and we went straight to the endovascular center, patients received 13-14% less TPA, and they received more thrombectomies because they were there earlier. And that was counterbalanced only on the time to treatment. So they received earlier TPA treatment when going to the local stroke center, and earlier thrombectomy when they went directly to the comprehensive stroke center. But at the end, the interesting thing is here is the distribution of the disability between both strategies. And you can see that basically it's the same. It does not improve your outcome to bypass the closest center and delay IV TPA treatment. And there are several explanations for this. Why is that? Why, if you all think about the strong benefits of thrombectomy, why if we delay thrombectomy by stopping at the closest center, we still have a similar distribution of disability. So we cannot make a clear recommendation. Look at this. This is from the same trial. The patients, about 700 patients were directly to the thrombectomy and others to the local primary stroke center. At the primary stroke center, about 200 patients had a confirmed large vessel occlusion, and they were treated, many of them with TPA. These patients that had a confirmed large vessel occlusion at the primary stroke center, when they got to the endovascular stroke center, 20% of them, 1 in 5, recanalized before endovascular treatment was initiated. So it was never needed. And this so when this happened in my stroke center, we say TPA works. So this is our phrase here, TPA works. And we remind ourselves that TPA works. And not only this, so we anticipated, we brought forward reperfusion in these patients during the transfer because we gave TPA before. And this is related with this study that we published almost 10 years ago now. But time is brain, and lytics improve. So the earlier we treat, the better, because the infarct is going to be smaller. But also, it is related to reperfusion. A fresh MCA occlusion that is treated with IV TPA within what we call the golden hour or the golden 90 minutes, let's call it here, the chances to recanalize this artery is 62%. And if we go further along the time window, as we get closer to 4.5 hours, the chances to recanalize the same occlusion is progressively lower. What is that? Because over time, once the clot is impacted there in your MCA, it will start to grow, but also the blood pressure will condensate it, will make it more dense. And TPA, once we give TPA later, it will be more difficult to recognize. On the other hand, a very fresh clot that just got there a few minutes later is going to be much easier to permeate and recanalize with IV TPA. So that brings us to these famous drawings in which, when you do not give lytic treatment, you have all these patients with bad outcomes, and you increase your number of patients that you are benefiting with a good outcome if you treat in the 3 to 4.5 hours, the 1 to 1.5 hours, and if we treat in the golden hour, basically you have 2-3 times more patients that benefited from the treatment because you treat them earlier. And this brings us to these famous mobile stroke units that in some circumstances are extremely helpful to initiate the treatment in the golden hour. Now, what about the transfers? A few words about giving TPA at a primary stroke center and transfer the patient for thrombectomy to the comprehensive. This is, and go forward here, a recommendation, a clear recommendation by the guidelines. You should start as soon as possible your IV TPA in the primary stroke center, and with no further delay, call the ambulance or put this patient in an ambulance and transfer him. So no waiting for improvement, no waiting for recanalization. We assume that it might occur, but we still transfer the patient. But we need to make sure that we have clear protocols for the TPA infusion during the transfer. So you need to work with the ambulances. They need to be able to keep and maintain the pump with the TPA, to monitor the blood pressure, to treat hypertension if it occurs during transfer, and eventually, if this is not controlled or the patient is worsening, you should discontinue the TPA. So it's important to have, it's not frequent that these things happen, but you should have in place your protocols and discuss them before you do that. But again, no waiting for transferring, but transferring should be under protocolized circumstances and with everybody knowing what to do in case of any change. So how do we do that in our center? We are pre-alerted by EMS always. We send somebody. This is the same neurologist that is waiting for the patient, like in the doorway. This is a hallway so we try to skip the emergency room. We communicate to all the team through these chats, and the patient is transferred by paramedics directly to the CT scan, where after non-contrast CT, this is all you need. In the 4.5 windows, you only need a non-contrast CT. At this point, while you are acquiring the non-contrast CT, this is when you spend a few minutes to talk with the family, if they are present, to gather all the necessary information and to explain the risks and benefits of the potential thrombolytic treatment. Then you analyze your non-contrast, and at this point, we start the TPA bolus. So many times, imaging is done within 12-15 minutes from arrival. TPA bolus is given within 20, maximum 25 minutes from arrival to the hospital. And then, while we prepare the pump for the continuous infusion of a 60-minute infusion, it will take 3-4 minutes. This is the time that we use to acquire the contrast imaging, the CTA and the CTP that might indicate a thrombectomy. And then the patient will be transferred. But we don't wait for the contrast imaging to initiate the TPA bolus. Now, this is another frequent question. Should we avoid the lytics if we can right away start a thrombectomy? And it makes a lot of sense, right? Because, why would I give a TPA if within 10 minutes, 15 minutes, I can start my thrombectomy? So there are more than 5 trials, randomized clinical trials that have studied or tried to give an answer. And basically, the truth is there are not big differences between skipping or not this bridging TPA. But at the end, this meta-analysis with about more than 2,000 patients concluded that here are the differences. There are slight differences, but there are still differences favoring intravenous thrombolysis. So you would see that the rates of good or perfect outcomes are higher. The rates of reperfusions, complete reperfusion, is also higher among those patients who receive thrombectomy. And here you can see the distribution. It's not a massive shift, but there's 2-3% more patients with good outcomes, MRS 0, 1, 2, in the group of patients that receive endovascular treatment. And not only this, so all the patients basically are still shifted toward favoring the intravenous thrombolysis strategy, except clearly these ones, those with a low aspects, in which if there's a extends signs of early ischemia, we all agree that those patients should not be treated with IVTPA, but all others, and this is very time sensitive. See, look here, the earlier you give the TPA, it seems to favor even better IVTPA. And I show you in the next slides, this. So here you can see the primary outcome of the IRIS meta-analysis that I mentioned earlier. The combination TPA plus thrombectomy versus thrombectomy alone favors the combination, so the odds of good outcome are higher the earlier you treat the patient. So if you treat the patient beyond 3 hours, maybe the benefits are not clear. But if you can do it quick and fast, and as I said, it all goes in line. The earlier you give the IVTPA, the higher is going to be the benefit of this TPA. So try to do things fast, not to waste time, and do not skip the IVTPA. So it is a clear benefit if you can treat within 2 hours and 15 minutes, and then it's progressively lost, this benefit. But here you can see again, if you treat within the 2.5 hours, a clear benefit from the combination, and then it's progressively lost. Now, that led to this expedited recommendation by the European Stroke Organization that reminds us that we probably should not skip the IVTPA in these situations, because we are still helping the patient. Now, talking about complications, what happened when we have an acute stroke patient, we initiated the thrombolysis, and patients suddenly have one of these symptoms or all of those. So this is maybe we may think about asymptomatic intracranial hemorrhage, but the mechanism of early neurological deterioration, this is the term that we use, early neurological deterioration, can be several. Many times it's a reocclusion. Some other times it's an extension or a progressing stroke, and there is start to be edema. So that's another of, and also, yes, of course, sometimes we have hemorrhages. But look at this, not all the hemorrhages are the same. As I said before, we have all these types that I described earlier, and it is paradoxically, the hemorrhagic infarctions, type 1 and type 2, have been correlated with better outcomes. The odds ratio is below 1, and PH1s and PH2 parenchymal hematomas, let's dig one, are associated with worse outcomes. So hemorrhagic petechias like this are probably a sign of reperfusion. If you have a reperfusion on you might have some petechia, but it doesn't necessarily mean that the patient will worsen. On the contrary, it will mean probably that the patient will have a better outcome. And this is different from these hematomas that are perfectly confluent hematomas with mass effects. Those are obviously related with worse outcomes, and we need to treat them. Yes, right? This is in all the guidelines. There are many papers explaining us how we should treat these guidelines. The truth is that in 23 or 4 years that I've been practicing, I very few times was able to start an effective treatment, because this usually happens so fast, the patient deteriorates so fast that there's not much time. But we all should know that, of course, we should preserve the respiratory airway, the airway, try to lower the blood pressure, and try to prevent hematoma expansion, yes, with some kind of reversal agents, which I think I gave one or twice in 25 years. So basically there is no time, but yes, we need to know the list. Cryoprecipitates will work for all symptomatic intracranial hemorrhages. Antifibrinolytic agents, like the ones I'm showing here, may also help. Platelets, fresh frozen plasma. Yeah, we should know that, but the truth is that when and we should give them, but when one of these hemorrhagic complications occurs, and at the time that we repeated the CT scan to confirm that this is a hemorrhage, many times it's so massive that there's not much we can do to prevent growth, right? And obviously control the blood pressure as shown here with these limits, again within 180 limits. But first thing you need to do is to confirm with a CT scan. I forget to say that, but you need to bring the patient again to the CT scan, and this takes minutes, and the hematoma continues to expand before you can start any of these measures, these measures, right? And yes, you can speak with neurosurgeons. Again, it's a possibility that unfortunately is not done very often for the same reasons, right? Extracranial hemorrhages, of course, they can occur, but they are rather rare, as you can see here. So rather rare, but yes, of course, they can occur, and we need to try to avoid them by trying to go through the exclusion criteria. If there's any recent surgery or any history of bleeding in another part of the body, we need to avoid thrombolytics, of course. And another complication that is very frequently cited but very infrequently seen is angioedema, is this swelling of half of the mouth, and sometimes it can go worse. It's like an allergic reaction that happens more often, like 6 times more often if the patient is on ACE inhibitors, or also 3 times more often if it's among women. 2/3 of the times it's in the contralateral side of the stroke location. So there seems to be higher frequency when there is an involvement of the insula. So this is very, very interesting, but it's very infrequent. Most of the times with some Benadryl, ranitidine, it's suggested here, it's sufficient. If it goes further, you should use some steroids, and very infrequently you need a higher level of care measures. And I've never seen a patient that needed to be intubated because of that, but obviously it's on the list if it affects the airway. But yeah, we should know about this, but we should, of course, not be worried about this. Here is what you need to do. If you see some kind of swelling in the lips, in the mouth of the patient, be confident that this most of the time will go away with no further complications. So the take-home message is follow the guidelines as much as possible, but treat the patients. Yes, the key is to inform everybody about the risk, benefits. Everybody feels comfortable with the treatment. And if there's a reluctance from the family, then you rather do not give it. But if you explain well the chances of benefits, the small chances of complications, everybody should be comfortable with the treatment. If there is an ICH, it's very unfortunate. There's try to do as to act as I just explained, but also know that there's not much we can do at this stage. And I think that's it. I will finish with this slide. I think right on time for a few questions.
Thank you, Dr. Mark Rebo. Thanks, Dr. Al-Mikhlafi. Yes, we left with a limited time for a few questions, so I will go to the questions from the audience here, and I will encourage everyone to share their questions on the Q&A. Our speakers, maybe later, they can come to your questions. So let us start with the first questions to Dr. Rebo. For a patient who is on adoxaban for 1 year for cardiac condition, and he had an ischemic cerebral stroke, should we start him on aspirin 81 milligram by Dr. Ram from Bahrain?
Yeah, well, that is an option. Another option is maybe consider the dabigatran high dose. This is we should wait if the patient has some increased risk of hemorrhage or bleeding. What is the exact reason of the cardiac condition? Probably an AFib without any valvular involvement. I would maybe think of adding an aspirin, but also maybe of switching the DOAC and thinking about the dabigatran in this case.
Interesting.
Yeah. And obviously also, if I may add, just looking what is the mechanism of stroke? Like, does the patient has carotid disease? Is it small vessel disease like lacunar, where might require just better secondary prevention? So that's again for Dr. kind of Ram, just look what was the mechanism of that stroke. But otherwise, I agree, perhaps aspirin for short term until that's figured out.
Okay. Another question is from Dr. Muhammad Farouk regarding the latest update regarding using the thrombolysis agent for acute stroke. Is there any shift, Dr. Mark, toward tenecteplase to replace the TPA? Is there any problem with that one? Many centers in Canada, it has been now I think Muhammad coast to coast tenecteplase has been used. Any update about that, Mark?
So yeah, it is obvious, and it's there are many publications, growing number of publications suggesting that TNK is at least as effective. It has, in my opinion, the biggest advantage is for transfers. It simplifies the logistics of transfers. You forget about the infusion pumps, and everything should go easier and faster. I think there is still some reluctance to widely recommend switching to TNK, mainly for regulatory reasons. I think the science is there suggesting, as I say, the efficacy. In our region, there is not always access to tenecteplase for stroke. There's also problems in the supply for us, so that's an issue. And we still use Actilis TPA. But maybe my colleague he can tell us if they switched in Canada for tenecteplase broadly or not yet.
Yeah, so many centers, Dr. Rebo, have switched, although still Health Canada didn't issue that like a note that tenecteplase can be used, but many provinces have switched to tenecteplase, or at least gave physicians the option of either using alteplase or tenecteplase for acute ischemic stroke patients.
Dr. Muhammad, to your presentation, which was impressive, the way that you collect all this, and I would like to remind all our audience, there's a huge number there, that these will be on our website and the YouTube channel, free recorded 90 minutes, that we will encourage your resident, your fellows, your junior doctors to share this video, and it will be there for free. Dr. Muhammad, with the new data, we are having now a joke in my hospital that everyone will come with LVO, will go for thrombectomy. With the new data, everyone should go and consider LVO. How can we say this with the current data? Is there anything should control this gate? Because everything is coming is LVO and they should go for thrombectomy.
Yeah, so that's an interesting question, Dr. Sahel. Like, obviously, resources are limited. And so if it comes to that, then obviously kind of prioritizing patient who would benefit the most. But like the evidence shows that the patient with stroke with an open artery would do much better in comparison to a patient with stroke, ischemic stroke with a blocked artery. So the evidence suggests treatment. However, as you saw, like it is still concerning to see that almost half of the patients who received treated ended up with some form of at least moderate disability. But still, they are better off compared to patients who didn't receive thrombectomy. So prioritize your patients, treat kind of within the guidelines. So current guidelines is up to 24 hours, and in selected patient in the late window, although with Mr. Clean that it shows at least that reperfusion when looking at the late window. So I should say that up to 12 hours, I think we have evidence now, even large core perhaps benefit, but sooner better is the better. But for the late time window, still we are targeting patients with relatively small core, either with aspects or CT perfusion and with proximal occlusion. And yes, I don't know whether Dr. Rebo has anything to add, but it's an interesting question.
Perfect, perfectly agree.
So let us to address this, because many of the clinical trials which came speaking about the LVO, the perfusion study is not available in most of the centers across the region. Maybe there's few centers there has the luxurious of having the perfusion study, MRI or CT. MRI, CT perfusion, MRI availability is not there during midnight, and this will take time. It depends where is the location of the MRI. So if we are going to put a small guidelines for a CT angio, when to go for thrombectomy in these patients who's coming less than 6 hours, last time seen normal, those patients between 6 and 12 hours, more than 12 hours, with aspect above 6, let us to say. Rebo.
So, as much as the data presented by Mohammed were recent, there was another trial presented just a few days ago. You may have heard of the LAST trial, which is also a large core trial, the last but not the least of these trials that was accomplished and finished. It was similar to the other large core trials, but it included patients with aspects 0, 1, and 2. And there were, I believe, like 2 or 3. And you do like, this is the first thing that, how can you consider treating a patient with an aspects of 0? And guess what?
On MRI, yes.
On an MRI, but still. But 80% had an MRI, 20% had a CT. And guess what? There is still benefit for patients with aspects as low as 0. So unbelievable. A few years ago, if that was a isolated trial, we would all think, oh, this is biased, skewed. But all these 5 trials point to the same direction, that larger cores still benefit, the most large cores. So again, I would stop using CT perfusion to assess the core, and also from the select to trial cores as large as 150 milliliters on CTP, they still benefit from thrombectomy. So yes, I love CT perfusion for other things, to detect distal vessel occlusions, to include more patients, or eventually include more patients in which an occlusion was not clear on CTA. No, you can use the information about the core to give some kind of prognostic information. Yes, the patient has a large core on CTP and is probably going to have a bad outcome. But you should know that whatever bad is this outcome, it's going to be better if you do a thrombectomy. And not only this, you're not going to increase the likelihood of a severely disabled patient with an MRS of 5. The last trial showed a reduction in mortality, but not an increase in MRS5. The number of MRS5 were exactly the same, 17% in both arms. So basically what you're doing, you are reducing mortality and gaining MRS 0, 1, 2, 3, and 4, but not 5s. So how this translates to imaging protocols. I would say imaging protocols with a plain CT and a CTA to confirm an occlusion, that should be enough to indicate a thrombectomy. I would say no matter what is the aspects, unless it's a clear infarct with mass effect and misline shift, that is another thing. But even if the hypodense signs are extensive, I would still, the patient will still benefit from thrombectomy, although his outcome is really probably bad, but it's going to be better with a thrombectomy.
And that's very important to clarify when discussing with the family, that it, not to paint, like obviously that the patient, this procedure will make the whole difference. It will make difference, but overall, as Mark said, it will be poor prognosis relatively in patients, the larger the core and more established the stroke. So, but I agree, again, like even select two patients with mismatch or without mismatch in CT perfusion, they did better with reperfusion, which adds to the argument that CT and CT angiogram, all that is needed for decision making.
Super. I have 3 minutes left, so I will try to shrink all the questions very quickly. Dr. Zul asked, what is the difference of using TPA in anterior versus posterior circulation? Is there any different, Mark?
So if something, to me, I think it's more effective in the posterior circulation. But again, you should use it in both if indicated. But data suggests that the benefits might be higher in the posterior. But
so we are using it for the anterior and posterior circulation.
You should.
Yes.
Definitely.
Dr. Muhammad, in case of hemorrhagic transformation of large infarction, should mannitol be given to these patients, and when to start it? Any evidence?
Yeah, so mannitol is a bridging, so it has a very short half-life. It can actually cause sometimes rebound, increased intracranial pressure. So mannitol is a bridge toward doing a definitive treatment, such as possibly hemicraniectomy if indicated. But other than that, like I think hypertonic saline may offer slightly better advantage over mannitol as a maintenance treatment, but a definitive treatment if indicated would be also needed.
Okay, there's a questions, Dr. Mark, from Dr. Almato. Kindly, a patient with atrial fibrillation and acute ischemic stroke with large infarction, when is the appropriate time to start the anticoagulation for the AFib?
So there's a very nice trial, Evian trial from a Swiss group, showing very well that in the delays that you need. So we all think that very large trials, you need a few days delay before you start thrombectomy. Think about what are you looking for with starting anticoagulation. You need to know what do you want to treat. If what you're willing to treat is another emboli from a cardiac source, this is relatively infrequent in the early time, in the first days. So if possible, I would perform a TEE, and I will confirm that there is no an alarming source of emboli, like a floating clot. There, if it's just AFib, the chances of early recurrence are relatively low, and I think you should wait a few days until you start anticoagulation.
Excellent. Dr. Muhammad from Dr. Muhad, any preference of antihypertensive medicine in treatment of acute stroke patients after thrombolysis?
Yeah, so I mean, I divide the time. So in the initial first 24 hours, you want to make sure that the blood pressure is relatively below 165. So using intravenous agents such as labetalol or hydralazine, whichever agent is available, is advised. But at 24 hours and forward, gradually starting whichever is available. I think thiazide, if the patient is diuretic, an ACE inhibitor, or an ARB, if the patient has a cardiac history, perhaps a beta blocker. So tailored to the patient, but intravenous in the first 12 hours, especially if the blood pressure is very high, and then from that start oral gradually.
Last questions. Dr. Mekhlafi was answering this question or in process of answering this. Is CT alone with aspect of 0 is enough for a patient came within 6 to 12 hours, Dr. Mekhlafi? Mark.
So, yeah, so aspect is a visual. I was typing that it's a visual qualitative. So even if a small area seems to have a hypodensity or kind of gray-white matter indifferentiation, it will be scored on the aspect. So an aspect of 0 overall, the infarct volume may still be relatively small. However, if it's an established area, it's hypodensity. If there is, as Dr. Rebo was saying, midline shift, I would avoid aspects. And again, like these trials are coming, and I was stressing that it's 0 on MRI, meaning that you could see the areas and score them clearly, as opposed to CT when we may not be sure. But I'd be hesitant with an aspect of 0, especially if the patient is 6 hours or beyond to treat, unless in a very small window, a young patient previously independent, last seen well was confirmed. But again, make sure that the family is ready for a poor outcome.
So what I would add is the last trial included patients in the 0 to 6 hours window. So that would not apply to like here a patient to 12 hours with an aspect of 0. Is it still beneficial? I don't know. Then of course, as Mohammed just said, on a CT scan, you have aspects of 0 and aspects of 0, meaning that some of them can be clearly black or hypodense. And you can have an aspect of 0 which is quite patchy with some areas that you think still you doubt, and so take that into account. It's not all zeros are the same.
At the end, our audience, I'm so glad today that I have this nice, wonderful collaboration and combination between Dr. Mark Rebo from Barcelona and Dr. Mohammed Mekhlafi from Calgary, Canada. It's honor to have MENASO having these two pioneers, physician, neurologist, stroke specialist, interventionist, to update us in the Middle East here about the new update in the thrombolysis and the clinical trials which came just recently. Dr. Mekhlafi, thanks for being with us today. Dr. Mark Rebo, thanks to have you with us tonight. And I'm sure that one day you will be here in Middle East and we will have a dinner together. At the end, I would like to thank all our audience for their participation. There will be 2 CME hours which will be shared and sent to your emails. And have a great night. Thank you for being with us tonight.
Thank you very much.
Allah يفتح عليك محمد. شكرا جزيلا. Thank you, Dr. Mark. Have a great night. Bye-bye. Assalamu alaikum.